Hello, everyone, and welcome to this week's live training. Hello to everybody that's watching the Facebook group. Hello to everyone that is watching on Instagram. So today we're going to be talking about treating low-level patients. So maybe patients who either need a lot of assistance or they don't move very much, they have very little function. That's the goal for today's live stream. So thank you for coming. I am Dr. Jody Miller. I'm a physical therapist and a mentor to PT students and new grads. I've worked in just about every setting that there is for PTs to work in. I've done peds, early intervention, I've done outpatient, I've done acute care, I've done oncology. Most of my career has been in skilled nursing. I was a rehab director. I was also a staff PT. And now I own a cash-based practice in Florida, and I'm also the owner of Clinical Connections Mentoring, which is where you are today. So what I would like you to do, if you're watching live, either on Instagram or Facebook, please type in the comments, tell me who you are and where you're watching from. I am, like I said, I'm Dr. Jody Miller, and I'm in the Tampa area, but I like to know who I'm talking to. So please also let me know if you're watching live or if you are watching the replay. So if you're watching live, go ahead, type live. If you're watching the replay, type replay. I just want to know who you are. So again, thank you for coming. Sorry, Instagram is being a little bit weird. Okay. So let's kind of get started a little bit. So today I'm going to really be giving you a lot of tips for creating treatment sessions so that you can gain confidence when you're working with every type of patient, regardless of their level of function. So this is a topic that I get a lot of questions about. I'm constantly getting messages from students and even new grads about, oh, I don't know what to do with those lower level patients. It seems that schools really equip you for treating higher level patients like athletes or kind of like that everyday person, the average Joe. But when lower functioning patients show up on your schedule, students and new grads tend to have a tendency to kind of freeze up and they're like, oh crap, I don't know what to do. I don't know where to start. I don't know how to progress these patients. So that's what I wanted to talk about today. I also get a ton of questions about regressing patients. So you're going along and they're moving well, and then they start to decline. And sometimes new grads and students are like, ooh, I don't know how to go backwards. I don't know how to make things easier for my patients. So those are the types of things that we're going to talk about today. So everybody knows, right, that for regressing patients, we're going to lower the reps or we're going to lower the weight. But how do you regress an exercise when you're working on like functional skills, or for patients who can only do simple things without even weight? They can't even start with weight. So how do you regress from there? So those are the types of things that we're going to talk about today. We'll also talk about how to know when to regress a patient. So let's start with a little bit of fun. Something's going on with Instagram, so I'm going to look at that in a second. But so while I'm looking at that, tell me in the chat, what's your favorite exercise or activity to prescribe? And let's do that specifically for lower level patients. So go ahead and type those. And if anybody is watching on Instagram, please tell me if y'all can see me and hear me. Give me a like, or a thumbs up emoji or something if you're watching on Instagram and you can hear me or see me. Okay. There we go. Hi. Okay, so it is working on Instagram. Thank you. Okay, so who watching, whether you're watching on Instagram or Facebook, who has found yourself struggling to work with that lower functioning patient? Like you're racking your brain, trying to think of all the different types of exercises. Maybe you find yourself in the shower or driving on the way home. and all you're doing is trying to brainstorm and think of different treatment ideas for your lower level patients. But maybe you're like, all you can think of is, oh, I only know squats and deadlifts and overhead presses. But that patient can't even roll over and get out of bed. And that's where you feel stuck. Or maybe all you can think of is ankle pumps and quad sets, but you and your patient are already bored out of your mind doing those things. And that's where you kind of feel stuck. So give me a wave, give me a thumbs down. Let's do a thumbs down if you've ever found yourself in that situation. Maybe you're getting frustrated because you know there's really good options out there. You just can't seem to figure out what they are. Hmm. Yep. So there's nobody's alone here. This happens very frequently. So whether you're a student or a new grad watching, you may feel overwhelmed with having to figure out what to do with your lower level patients, or just maybe you feel like you shouldn't be working with these types of patients because you don't know what you're doing. Maybe that's how you feel, but you also want to feel competent enough so that you can help them reach their goals. Problem is, you've likely been told that you should know exactly what you're doing in order to be a great clinician. And to do that, you need to load up on all your CEUs, maybe do a residency in order to figure it out. But that makes you feel frustrated, deflated, and even alone. And that makes complete sense if that is you. But I believe that just because you've successfully passed your clinicals and you got entry level marks on everything, you graduated PT school, or even that you just completed your didactic coursework and you're on a clinical, that doesn't mean you have to do it by yourself, go it alone, figure everything out on your own and burn out in that process, right? When you surround yourself with support and guidance by someone who gets you, you'll be able to unlock that strength and confidence that you're looking for to be able to get those positive outcomes with your patients, regardless of their functional level. You can continue to grow as a clinician, and you can set up a career that supports a burnout free work-life balance that allows you freedom to enjoy your nights and weekends. And that's what I'm here to help you do. So to begin, I want you to picture a patient that you've worked with that has a low level of function. Okay. I want everybody watching, just pick a patient. I want you to get a patient in your head. Maybe it's someone who wants to walk, but they've been so deconditioned from multiple comorbidities, and they've been in a wheelchair for the past year, right? Maybe it's someone who just doesn't have the strength to roll over or sit at the edge of the bed. Maybe it's someone who just fatigues and gets short of breath after standing up for just 30 seconds. Or maybe it's someone in the ICU, right? Orders are that they cannot get out of bed. Maybe they're intubated and you're like, I don't even know where to begin with this person. So um, think of that person. If you want, go ahead and share that in the comments. Kind of describe that type of patient. Okay, I want everyone to have a kind of get a patient in mind as we talk through some of these tips that I have. Okay, so first, I want you to remember before we start talking about any of this stuff, remember that that patient is somebody's parent, sibling, son or daughter, best friend, cousin, coworker. Even though they're currently functioning at a low level and it can be really frustrating for you, they likely still have hopes and goals, right? They have things that they want to get to. Most people in this position didn't just get there by chance, right? Likely there's a series of events either in their control or out of their control that led them into that situation, right? I'll share my patient that I'm thinking of. So I once had a patient in skilled nursing. She had been stuck in her bed for over a year because of basically debilitating back pain. Her family, due to some cultural beliefs, allowed her to stay in bed, and they basically cared for her and did everything. And I mean everything. They brought her food, they bathed her in bed, they toileted her in bed, they dressed her in bed, everything, to the point that she became completely dependent and still had the back pain. She'd ended up in the hospital. I can't remember the reason she ended up in the hospital. It might have been a flare up of that back pain, but then she was sent to rehab because of her low function. And then that's where I met her. So I remember going to her room to do her eval. I took her history. And you better believe the first thing I did was ask her what her goals were, right? She said, I want to walk. I want to walk again. I said, okay, then that's what we're going to do. I'll come back to her later after we talk about some other things. Okay. So I hope everyone has their patient in their mind. You're thinking about that patient. So when you're treating a patient who is lower level, the best place to start is by asking them what their goals are. So if you're stuck, you're like, ugh, I'm tired of ankle pumps and quad sets and hip adduction squeezes. I want something more for this person. Ask them what their goals are. What did they like to do before they found themselves in this situation? Trust me, everybody enjoyed doing something. Your job to start out with is to figure out what that thing was. Okay. From here, you can get those creative juices flowing, right? If the person liked to garden, you can have them add soil to pot using garden tools, right? They can sit in a hospital bed, right? Maybe they're supporting and sitting in supported sitting, or maybe progressing to the edge of bed, wherever that person is in their current functional level. If they like to garden, figure out something to do with them for gardening. And it can be as simple as, putting pot soil into a pot using a shovel, a small shovel, or moving the soil from one pot to another, whatever. It's getting something to activate while they're doing the thing that they like, right? Maybe start supported sitting, then you progress them to sitting at the edge of the bed, or progressing, then they're sitting on uneven surfaces on the edge of the bed, and maybe they eventually can do it standing. Maybe the person just loved working as a mechanic, or they like to fix things around the house. Give them some small tools, nuts and bolts, let them play with those things so they're using their hands. And again, you can play with the position that they're sitting in. So maybe you try semi-reclined, and then you move them to supported sitting, and then you move them to sitting under your bed, and then you move them to standing. So they're still doing something that they love, but you're playing with the positions that they're in. Okay. This brings me to my next tip, which is remember your developmental positions and use them. Those are things like supine, semi-reclined, ring sitting, long sitting, supported sitting on the edge of bed, unsupported sitting on the edge of the bed. So maybe you're helping them sit, or maybe they're using two hands. Progress them to no hands, right? Quadruped, tall kneeling, half kneeling, standing without upper extremity support, standing with upper extremity support. So remember those developmental positions. I just named a ton of different positions that you can do treatments in, right? So if a patient can't stand, you can do a lot of stuff in all the different sitting positions, get that trunk to start to work and build from there, right? So it can be something as simple as starting by maybe it's that patient in the ICU, right? They're intubated, they're not quite ready to get out of bed yet. Simple. You can start with changing the position of the head of the hospital bed. So maybe you have them with the head of the bed at like 30 degrees, right? And then you have them reaching for different things with one arm, reach for with one arm, reach for the other, reach across midline. And then you can change how high the head of the bed is, right? Maybe change it to 45 degrees, have them start to reach further across midline, or reaching, more to the side, more lateral instead of straight forward reaching. Changing the head of the bed is going to start to get that core to activate more. It's not a big task, but it's really beneficial for that low level patient. Okay. I love, one of my favorite activities to do is to do things in half kneeling and tall kneeling and quadruped. I always feel like these three positions often get missed. They get forgotten about. Everyone wants to do lying, sitting, and standing, but half kneeling, tall kneeling, and quadruped can get a lot of things done, right? They're super functional, right? People have to get up and down off the floor. All of those positions are needed to get up and down the floor, but you can start there, right? And the nice thing about these positions is you're getting a lot of muscles working at one time, which is why it's a little bit more functional. Instead of just doing quad sets to activate the quads, you can get them into tall kneeling, and then you're getting the glutes and the hamstrings and the quads and the core working, right? Okay. All right, so my next tip is to use your PNF patterns and techniques, right? I'm not talking just about like contract, relax, not that type of PNF, not PNF stretching. Talking about those D1 and D2 patterns. Remember those, right? D1 and D2 with the upper and lower extremity. These patterns are really functional because they add the rotational component, and they can be extremely helpful for your low level patients, especially those that have been in bed for quite a while. Using D1 and D2 flexion and extension patterns for the upper and lower extremity, it's a really, really great place to start. It's a simple place to start. If that patient just doesn't have a lot of strength, there's not a lot of core yet, or not a lot of mobility. So when I think about this, it reminds me of the school that I'm an adjunct faculty at. a couple years ago at graduation, we had a student share a story. He was on his acute care clinical rotation. They had a patient that was unfunded and super low level. She might have even been in a coma. I don't remember all the details around that actual case, but she was really, really low level, basically bedbound. Patient wasn't on their caseload, but the student asked the CI if he could work with the patient. CI agreed, and the only thing the patient did was PNF to the extremities. Started with simple PNF D1, D2 patterns, right, to the arms and the legs. Started with passive. As she became more alert, moved into active assisted D1, D2 patterns, did D1, D, or did all the patterns to the pelvis and the scapula as she became more awake and more active. PNF was the name of the game for that patient. He also progressed her to doing PNF in functional positions, and then started to add in some other PNF techniques like the chop and the lift, pull and thrust that worked more on, getting her entire body involved into the movement pattern. And he worked with that patient until she walked out of the hospital, all starting with PNF techniques and patterns. Okay. PNF sometimes can be scary because there's a lot going on with that pattern. It doesn't have to be that detailed. Just remember the general direction of that pattern, whether it's D1 or D2, right? Just start working there. That's a really, really easy place to start for your lower level patients. Okay. So next, I want to remind you, keep it simple. Your interventions do not have to be super fancy. So first, think about the task that the patient is having trouble with. Can you break down that task? If you can break it down, break it into the parts and work on the parts, and then bring it back together and work on the whole task all together at one time. Okay. So example, supine to sit, right? First thing that has to happen for supine to sit, probably want to bring their knees up. Then you're going to want to work on reaching across midline. So maybe that's where you start. And that's again where your D1, D2 patterns can come in, right? Have the patient just reach across midline with their upper extremity. Go both ways, right? Break down that task, right? You also need to then do some trunk rotation, add in some hip flexion. Once they get to their side, they got to bring their knees up so then they can drop them off and push up to sitting, right? So that's triceps. So instead of just doing, triceps with a TheraBand, can you get them to sideline and just work on pushing up? So starting in that sideline position and pushing up to sitting if they can, or maybe it's just straightening the elbow to activate the triceps. Functional position, it's part of supine to sit, and it's a really good activity for your lower level functioning patients. Once they're sitting, you can still break it down. Can they scoot forward? Can they scoot backward? Can they scoot side to side, right? So you might start working on each of these parts individually. And remember, it needs to be done in the position that it needs to happen. So like I said, with the triceps, you can start with tricep extensions and supine, but really they need triceps in a weight bearing position to be able to push up into sitting or to be able to push up into standing, right? So when you're breaking down that whole task into different parts, think about what position they need to be in to activate that muscle and work there, okay? If the patient needs assistance with getting out of bed, work on rolling side to side, work on transitions from sideline to pushing to sit. Again, kind of think about that tricep strength. Maybe the patient needs help with scooting, right? Work on scooting forward and backward, side to side, maybe just weight shifting forward onto their feet and then coming back. Maybe they don't even lift their butt, but you're just working on shifting, putting more weight onto their feet and then coming back. That may be your session. You may not get them to standing, right? If they're that low level that they don't have the strength to stand, that's okay. Work on sitting and just maybe get them to learn how to weight shift forward, put some weight through their feet, right? Maybe weight shift one side to the other. Can they shift to one hip? Can they shift to the other? Hi, Luis. If a patient needs help with sit to stand, work on sit to stand from varying heights. This is a pretty easy one. Everybody tends to love sit to stands, but just make sure you're varying the heights, vary the surface. Can they do it with support? Can they do it without upper extremity support, right? If you're in an ICU or an acute care hospital room, just raise the bed, change the heights of the bed. Can they get up from their bed? Can they get up from a chair, the hospital chair, right? You may even find yourself in a home health setting, right? Patient's low level has so much trouble getting up from chairs. There's different services within their house, the kitchen chair, their recliner chair, their couch, their bed. There's different heights of surfaces. So varying the task is going to help with these lower level patients. Also think about when you're breaking down functional mobility, tasks like these, bed mobility, sit to stand, think about what muscles are needed. So let's take sit to stand. What muscles do you need to do sit to stand? And then from there, if they cannot do sit to stand yet, they're that low level, what other activities or exercises can you think to activate those muscles? So maybe glutes, quads. What exercise? You feel free to drop them in the comments. What other activities besides just straight sit to stand can be a good exercise for someone who's not ready for that? Feel free to drop it in the comments before I give you mine. Okay, so bridging, okay, there's the shorter quads and the longer quads, but again, those in quad sets, so it can get very boring. An easy one to do is bridging, right? And maybe it's just starting, can they get into the position, right? Then from there, can they lift their butt? You're getting quads, you're getting hamstrings, you're getting glutes. Also, same muscles you need for sit to stand. So if they're not quite strong enough or they're that low level that they can't do the exact task you want, what muscles do they need for that task and what other ways can you activate those muscles? Okay, so let's go back to my patient that I was telling you about in the skilled nursing facility who who wanted to walk again, but had been stuck in bed for over a year. So she actually had pretty good bed mobility, but had the most difficulty with sit to stands. She couldn't stand for a very long period of time and she couldn't walk very far because of all of it was based on her back pain. But then on top of that was the um, atrophy and decline in function because she'd been in bed for over a year. So we worked through all those things. We started with simple movements for her hip and her low back. So we did things like double knee to chest, single knee to chest. We did trunk rotations. We did pelvic tilts. Just really got her pelvis, her low back, her hips moving. We started with those in supine, but they weren't quad sets. They weren't ankle pumps, right? I did show her those things, but that she did on her own. That was like first session. These you're going to do in your room by yourself. You don't need me for these, right? Um, then as she got better with all that, we started to add resistance and reps, your normal way of progressing her. But then we started to focus on rolling, bridging, supine to sit, building up that strength and endurance for those functional tasks. We worked on sit to stand, varieties as a way to strengthen her lower body in that closed chain position, right? Can't always do open chain for functional tasks. There needs to be some closed chain activity. So she was doing the open chain on her own in her bed. And then during her therapy sessions, we worked on those closed chain lower body strengthening tasks. We worked on walking, a lot of walking. Let me tell you, this woman reached her goal of walking in about 2 weeks. Okay. She was able to walk with contact guard assist. I saw her 5 days a week. After 2 weeks, she was able to walk contact guard assist with a four-wheeled walker. But she could only go about 25 feet due to fatigue, shortness of breath, a little bit of back pain. And I'm going to bring in the other component to skilled nursing facility is I had to fight for her to get her insurance company to let her stay for one more week so that I can get her to be more independent with her bed mobility and to be able to walk further. The argument from that insurance company was, well, she's already at her prior level. They were fine with her being able to walk just 25 feet with a walker. This woman was not. She wanted to keep going, right? I was able to get one more week with her. After that week, when I discharged her, she was walking over 300 feet standby assist with that four-wheeled walker and was independent with all other mobility. Okay. Regardless of what I did with her, honestly, I think it was the fact that I listened to her, I encouraged her, I advocated for her, and I supported her goals. That's what got her walking over 300 feet again with that walker. Her back stopped hurting, didn't hurt anymore because she was moving again. She was able to get in and out of bed by herself and freaking walk with her walker by herself. All because of how I treated her, not necessarily what we did, but the fact that I listened to her and I encouraged her. Okay. So I also want to take a moment, talk about knowing when and how to progress and regress a patient, because this is, again, something I get a lot of questions about. And it tends to trip up students and new grads a lot. So my simplest answer for how do I know if I need to make it easier or harder, progress or regress that patient, use your RPE. It's so simple. It takes 2 seconds. You don't need anything, right? You can use it for Therex. You can use it for gait training. You can use it for balance training. You can use it for functional mobility training, right? If you're talking about those sit to stands that we've been talking about, ask the patient. Takes 2 seconds. On a scale of 0 to 10, how hard are you working right now, right? From here, you can determine if the patient's working at the level you want them to be, or do you need to change something? Is it too easy, too hard? If you're doing sit to stands and the patient's like, oh, this is a 2, you know you need to bump it up. If they say this is a 10, you got to change something and regress. And that goes back to everything else we talked about. Maybe it's changing the height of that chair, giving that patient more assistance, right? So other ways to regress some tasks for those lower level patients besides decreasing reps, decreasing weight, um, break down the task into parts, right? Decrease the range of motion of that task. So if you're talking about the sit to stands, change the height of the bed so they don't have to go up and down as high, or change the head of the bed. So if you're working on some trunk rotation or reaching, maybe you change the height of the bed, the head of the bed, so that they don't have to reach so far, right? Change the resistance, maybe give the patient more assistance. So maybe if you're trying to do min, but they're telling you, oh, this is an 8 out of 10 difficulty, give them a little bit more, give them that mod assist so they can be successful in that task and start to activate their muscles in different ranges of motion just because you're giving them a little bit more help. Remember, you can also move from closed chain to open chain, or go from another way to regress is if you're working on multiple muscle groups at one time and that's too hard for the patient, they're not able to do it, then go back to working on one single muscle at a time, then come back to combining the muscles again. So those are some easy ways to regress patients who are already at a lower level of function. Okay, so to recap, ask your patient what their goals are. From there, figure out how to create the task and meet their current level of function. Okay, spend time in your developmental positions, vary the treatments here, use PNF, especially for patients who are not strong enough to get out of bed yet. Don't forget those D1, D2 patterns for the arm, the leg. You can use the scapula, you can use the pelvis. That's a scapula and pelvis. Using both at one time is a really good way to help them start to roll, right? PNF patterns. Keep it simple. Break down the task if possible, and work on the parts, then put it back together and work on the whole task. You can't forget the whole task, right? You can break them up, but once you've broken them up and they're successful in the part, then you got to put the whole task back together. Listen to your patient. They will tell you what they want to do. Let this guide your treatments. Let them know you care, that you're there for them, and that you will fight for them to help them meet their goals. Okay. Use the RPE scale to determine if you need to progress, regress, the interventions that you've already chosen for that patient. They'll tell you if it's too hard or too easy. Okay. Bottom line, you can do way more than ankle pumps and quad sets with your lower level patients. You have so much more knowledge and so much more creativity than just doing those boring leg exercises for a patient who's so low level that they're just lying in bed. So for anyone watching in the Facebook group, I don't know if there's anybody here still. I think some people had to leave, but if anybody wants to volunteer to share a patient case, I will help you brainstorm some treatment ideas for that patient. So if you want to volunteer, go ahead and drop a me in the comments in the Facebook group. While I'm waiting to see if anybody wants to do that, I do want to say, I hope you learned something new today. Go ahead, drop in the comments your aha moment or something that really stood out for you, or something that maybe I forgot about that. I'm going to start using that. Tell me, what's something you heard today that you want to start using right away, or you're like, oh, that's a good idea. Okay, I'm going to give the Facebook group a little bit more time to see if anybody wants to share a case. Okay, it looks like nobody wants to volunteer today, and that's fine. I do want to thank everyone that came and watched today, whether you're watching on Instagram or you're watching in the Facebook group whether you're watching the replay or you watch live. Thank you very much for coming. Hope you learned something, and I will see you next time.